Hi, welcome to Rochester Regional Physical Therapy at Midtown Athletic Club. We're located in Brighton at the Midtown Athletic Club, right off of 590, 490 here. My name is Rick Fame. I'm the supervisor of the clinic. A little background about myself. I graduated PT school from Damon College in 1995. Went on after that to get my master's in orthopedic physical therapy. Have been with this organization, Genesee Hospital to Rochester Regional, since my graduation, and we've been out here at Midtown since 1997. And this is Jim Briggs.
Yeah, I'm Jim Briggs. I graduated in 1993 from Damon with my bachelor's, and I went back with Rick and we got our advanced master's in orthopedics. And I've been doing orthopedic physical therapy here for 24 years.
A little bit about our clinic and how we run things here. We book half-an-hour appointments with patients. Doesn't mean you stop. You're done at 30 minutes. We can go longer. And we pride ourselves in providing one-on-one personalized care. We focus our attention on your immediate needs and your individual needs in order to improve what you're coming in for, whether it's orthopedic, vestibular, balance issues. We also one of our therapists, Deanna Hayden, also provides care for lymphedema patients, but primarily we provide care for orthopedic injuries, post-surgical, whether it's spinal injury, any joint-related injury, soft tissue injury.
And we try to work closely with other professionals that you might be dealing with to have a smooth transition from like the rehabilitation process, maybe into a community fitness program or some other kind of endeavor that you might be involved in after rehab. So,
as you're watching this, if you have any questions, you can submit a question through the Facebook, and we can hopefully answer that question for you. This is our general treatment area back here, so if you want to scan around a little bit, this is our open little gym area here that we have. We have some treatment tables. We have some TheraBands, some weights back here, some cardio exercise equipment. What's nice about our situation, our facility, is we're directly attached to Midtown Athletic Club, which means we have full access to the club and all the weight training, cardio, open floor space. They have a basketball court, some open tennis court space that we can utilize for kind of higher functional level activities with the patients.
yeah, which helps us transition people from PT to maybe their gyms, because a lot of gym equipment is similar.
So we want to talk about a couple kind of patient issues we may work with, and how we kind of look at them, and how we kind of maybe add some or apply some exercises for these types of patients. If we can scan back around this way, we've got a physical therapy intern working with us. His name is Rob. He's from Dewaville College, and he's going to be our patient for today. So the first thing I want to talk about is many people come in with patellofemoral pain issues. Patellofemoral means that the kneecap, in conjunction with the knee, you're having pain or issues with that. It's anterior knee or front knee pain. Typically, it can be pain produced from kind of wearing of the cartilage under the kneecap onto the joint. It could be soft tissue, maybe a tendinitis of the patellar tendon here or the quadricep tendon. So whenever we evaluate a patient, again, we're looking at the whole patient. We're not looking just at the knee. We'll look up the chain at the hip or the back or the core. We even look down the chain at the ankle or the foot posture with a lower extremity patient like this. So if I was to evaluate Rob here, I would start looking at his overall posture and alignment. You usually have his shoes off, but we look at, arch position. Does he have a high arch? Does he have a kind of a flat foot posture? And based on that posture positioning of the foot, that can translate to different changes at alignment of the knee and at the hip. For instance, if Rob has a fallen arch on his left side, his foot will kind of roll in, which would turn his leg in a little bit, and his knee cap may point towards the inside a little bit. Would also kind of rotate his hip in as well. So you can see his alignment would be off compared to normally looking straight ahead like that. So if we can bolster that, maybe talk to him about getting some orthotics, that'll help position him better from the floor up. You can also have some issues at the hip. Some hip weakness or glute weakness is an important part that we may miss when we're looking at knees if you just look at the knees. So if you have weak glute muscles, specifically glute medius, the glute medius muscle is a hip abductor muscle. It kind of moves the leg or the hip away from the center. It also works as an external rotator of the lower extremity, meaning it'll rotate it out in this direction. So one test we do when standing, kind of a functional test that kind of assesses glute medius strength, is we call the Trendelenburg test. So I would have Rob stand just on his left leg and slightly bend that left knee. And we look at his pelvis here for the alignment in his pelvis. So if his glute medius is functioning appropriately and functioning in that position of weight bearing, it should stay level. Now let's pretend that you have a weak glute medius. So show me how you would compensate. So see how his hip dropped or his pelvis dropped on the right side here? That means that his left gluteus medius is not holding it up the way it should be, horizontal. Another kind of reaction he may do is he may lean towards that left side. No, the other way. Yeah, so another compensatory motion is if that muscle's weak, they'll lean towards that left side as they put the weight on his leg like that. So I'm going to show you a couple exercises how we kind of progress some glute medius strengthening, which we also often miss with knee issues. Any comments about this so far?
Well, yeah, the only thing I would add is, and Rick touched on it, is that a lot of times you got to be careful if you're going to any place specifically that's treating just the knee itself, because the knee often is not the culprit, it's the victim. And I always think about it as a hip, knee, and ankle is actually like a train, like a track, and the patella itself is the train on the track. In the old days, we used to try and tape and encourage the kneecap one way or another and work and worry about what the kneecap was doing. But now what we've realized is it's more of what's going on above and below that knee that causes where the train rides on the track. So you may go to physical therapy, when you come to us, we may do a lot of things that are remote from the knee to improve the mechanics at the knee and to take stress off the kneecap.
So we'll have Rob come down the table. We'll have you lie on your right side. So we're pretending he has weak hip abductors on his left. So we're going to start with modification exercises for hip abduction strengthening, which is this gluteus medius muscle, which we call the back pocket muscle. It's a hip abductor and an external rotator. So the kind of a low-level, easy starting exercise is called a level 1 clamshells, what we call it. So knees, hips are bent up, feet are together, and you're just going to open that knee, lift it up, and then return back down. So he'll go up as far as he can until that hip starts to roll back. When he starts to roll back, he's gone far enough, and he comes right back down. And he should be feeling what we call that back pocket muscle. So that's level 1. The next level of progression would be lifting the knee and foot together. So we kind of open up and lift up like that, and then lower down. Same idea, a little more work because he's lifting the whole leg at once. He's not rotating too far. We can also add TheraBands. We can add a resistive band around his knee, which is just offer a little more resistance, a little more tension.
Without taking the hair off his leg.
You can do feet together and open up. So it'll give more resistance to work that glute medius muscle. A further progression past that, we can take this off, is a sideline hip abduction. So in sideline, a pure hip abduction would be straight knee and lift up towards the ceiling and then back down. Now the thing that people often miss is that the hip is often kind of flexed forward when people do this. And when you do it, have it flexed forward, you're kind of working more that tensor fascia lata muscle, this muscle on the side of the hip, which we don't want to work. We want to work that glute medius. So you want to extend the hip a little bit behind you. So the foot should be a little bit behind your hip. Keep the knee straight and you're lifting up towards the ceiling. Nice control. And if you want to even further kind of engage that glute medius, he may externally rotate a little bit. Hold his toes pointing up slightly towards the ceiling and then back down. So that's another progression. I'm going to show you another progression in standing in a second, but while I have them on the table, I want to show that we do some kinesio taping. Come over on your back for me. So kinesio taping is this thing you see with all these athletes wearing, this colored tape that you can put on different parts of the body, knees, shoulders, calves, thighs, forearms. I'm going to show you just a quick tape job that we do. Oftentimes the kneecap, Jim mentioned about some tape that we may do to kind of help kind of mechanically stabilize the patella. Typically that kneecap may kind of start to glide lateral on the knee joint or not be positioned correctly. So we can apply some tape that kind of might help bolster that a little bit. It might give you a little bit of kind of neural feedback in trying to help maintain better alignment in the patella. This tape also helps with blood flow. It increases blood flow. It helps with pain control as well. And you can also tape for swelling. People have swelling. We can tape in a certain way to kind of reduce that. So I'll take this tape, I'm just going to rip it in half, and it has an elastic component. So it stretches. As I pull it, the tape will stretch. And we're going to apply a certain amount of tension or stretch on that when we apply the tape. All right, so I'm going to apply this to the lateral part of the knee. Good. Now you're going to bend the knee up. You're going to come around. And there's no tension on the ends. So there's tension on the middle, there's no tension on the ends of the tape. And it's functional. It doesn't restrict motion. It's going to help to kind of give him a kind of a guide of what he's feeling when he's putting weight on that leg and kind of keep that knee in better alignment. And it may help with the pain as well. It creates a lifting of the skin between the skin and the soft tissue and allows for more blood flow in there. So I want to show one exercise in standing, then we can talk about some posture stuff. So let's have you stand up. Can we come over to this counter here? So I want to show a weight-bearing kind of glute medius exercise, more functional kind of position for strengthening that glute medius muscle. So standing at the counter, stand on your left leg, and do like a little hip hike standing on his left. So he's engaging this muscle to kind of raise that pelvis up. He's contracting that glute medius muscle. Oftentimes people will compensate and they're firing this muscle in your back. It's called the quadratus lumborum muscle. It's a hip hiker on this side. We don't want that. We want this muscle purely contracting and just tilting that pelvis up and down. Anything to add to that?
Well, it's just, when we muscle test you, we muscle test into abduction where you're lying on your side and lifting. But that's not really a functional movement that we do every day. What Rick is doing is he's stabilizing and putting him in a functional position. This leg can't move anymore, so what happens is when this contracts, it lifts and levels the pelvis. So it's a good way to functionally work on hip stability to help support the knee and the foot down the chain.
Without totally missing exercises for the knee, we definitely want to work on quad strengthening and hamstring strengthening. So a nice functional exercise that's pretty safe for the knees is a partial lunge. So if you can face it this way. So with the left foot, we're going to have you step forward, land on your heel, shift your weight forward, and then push back off of that. So this is good for stability and kind of neuromuscular control and strengthening at the same time. Now, oftentimes, when you get people, again, with maybe a pronated foot, that fallen arch, or that weak gluteus medius muscle, oftentimes you see them step forward, that knee's going to go inward. And that's where Jim was talking about. You're taking the train off the tracks, because now those tracks aren't aligned correctly, and that train, that kneecap, will start to glide off those tracks. And that's where you start creating issues in that cartilage, because you're rubbing on that cartilage in an adverse way. So we tell them, train, tighten that glute medius as you step forward, keep that alignment, knee over toes, and then you push back off of that. So we train functionally. We're here watching these patients do this, so we're spending time. We're not having to just do exercises, go in a corner, come back, and let's see how you're doing. We're watching, make sure you're doing these exercises correctly.
Okay. The second thing I wanted to touch on was just posture, neck and shoulder type things. So I'm going to have Rob have a seat here. One of the things I noticed as I'm getting older in this profession is that people come in with a script from a doctor of a neck pain or shoulder pain, but it's very hard to say that this is just the problem. Oftentimes there's other joints, there's other regions of the body, of course, connected to that influence this. So a lot of my evals and stuff now are including neck, upper back, core, just to look at a shoulder. But one of the things that we have in modernized society is we tend to have this forward head and rounded back position. Doesn't seem like too big of a deal unless you do it for 5, 6, 8 hours a day. And what you have is you have this 8-pound to 13-pound head, which is forward of your center of gravity. When I say center of gravity, if I bring his ears, shoulders, and hips in alignment, that's the line of gravity. In this position, there's no real forward, backward, side to side, or rotational extra stress on any particular part of the spine. It's sharing responsibility. But if he slouches forward and lets his head go forward, it's been said that for every inch forward your head goes, there's an extra 10 pounds of shear and compression on your lower neck. And this is a common place to have a lot of problems in terms of mobility. And also these muscles that tether from the ears to the shoulder blades are being put on constant tension throughout the day. So gravity is a constant in physics, right? These muscles aren't a constant, so they can't handle the constant pull of gravity. And people start getting neck pain, they start getting pain and soreness, and they can't handle sitting all day. But they have to get their work done, so they forget about it and they just let it accumulate. Well, what we do, a lot of times, physical therapists will tell people, well, stretch it. Stretch your neck out. My problem is that this is already stretched out and strained. What I want to do with my people is I want to bring them back in line with gravity and take this off of stress so that this muscle can actually have a chance to heal and rest and not be stuck in a strained position. Also, if we turn Rob back this way, if he slouches and just kind of slouches down like, now watch his head motion. If we turn him to the right, maybe 50% of rotation. We turn him to the left, maybe 50%. He can look all the way down. Flexion's not a problem. Now, look all the way up. Not that much extension. That's just by virtue. He's lost range of motion by virtue of position. All these joints here are compressed and sheared forward. Now, if I bring them up, now go ahead and extend. Go back as far as you can. Full extension. That's a big difference in just the mechanics. You know, a lot of times we don't have to necessarily do something to you. You just need to know how your body works and how to move correctly and how to get out of the positions or things that might be perpetuating or causing your pain. You spend 8 hours a day relatively sedentary, not moving, and then you go like this and you go play tennis and you don't have the extension because you're tightened down and you can cause shoulder pain or neck pain. One of the other things that I think about is, come on over here for me, Rob. When I check a person with a neck or a shoulder problem, I have them lie right on the table without a pillow. And a lot of times I see this. Now, does that look comfortable or normal? Is that comfortable, Rob?
No.
No, his neck is all jacked back and he's not relaxed here. It's because he's gotten really stiff and this spine right in here, the thoracic and the top of the thoracic spine, the bottom of your neck, is basically stuck in flexion because it doesn't extend enough. So that's the first, when I see that, I know we have to make corrections. So one of the things I like to work on with people, and also, if you see he's kind of rounded, and these are tight, we got to get this down and we got to bring his head to there. That's what you should look like when you're lying down. So if this isn't moving, this can raise all kinds of havoc with your neck and your shoulder with shoulder function. So some of the things we work on, I mean, just at home, trying to open up your chest, you can use like a cane or a wand. Let me just grab one.
So Jim is talking about soft tissue tightness anteriorly in the chest, and in the back, it's all lengthened. So we've got to strengthen those posterior muscles to shorten them down, and then lengthen or stretch these front muscles that are tight.
And we also got to get this lower cervical, upper thoracic, this junction here, extending and moving. So a lot of times I'll have him bend his knee, keep his core tight, maybe even put a towel roll between his shoulder blades to open him up. And then I'll have him start moving at a very low level so that he's lengthening all this stuff that's kind of constantly being stretched and stuck forward. This is just a simple exercise. More importantly, though, is every day at work, every hour, he needs to take his body out of that stress position, work into extension, chin tucks and thoracic extension, so we'll show that. Come on. And just a quick thing before he sits down and I show you that. if he's in that position standing, so kind of getting, now raise both your arms overhead. That's as much elevation as he gets because he's already taken up the motion. He can't extend any further because he's stuck flexed. Now if we bring him down and we raise his chest, now go up overhead. He gains like 30 to 40 degrees of range of motion. So tell me, when you're doing things, when you're have a forward posture and you're constantly reaching overhead and you can't extend here or open up, you're jamming and you're causing rotator cuff impingement. So a lot of times, yeah, we can treat your rotator cuff and strengthen it, but we also got to look here and even as far down as your hip to try and get this posture and this stuff opened up so you don't get the impingement here. That's just a little side shoulder thing. Now have a seat. This is what I try and tell my people to do at work. So first of all, your butt should be way back in the chair, and your shoulders should be back. You can have the best, most expensive ergonomic chair in the world, but if you don't sit in it correctly, it doesn't do anything for you. So he's lined up so his ears, shoulders, and hips are in a straight line. So there's a little stress on his neck. So first thing you got to do is change your posture when you're working. And sometimes your place has an ergonomic specialist that can help you with that. The second thing is I tell them every hour to break up that flexion stress. I tell them to work on what's called a retraction. So put your finger on your chin. Start in good posture. And then I want you just to retract backwards. And pull back. Even hold it. And what he's doing is he's reversing the curve in the forward flexed posture that he's getting 8 hours a day. You've got to break it up. You got to keep it from getting stiff. And you got to reverse it over time. It's not going to happen in a day or two. It's going to happen practice and time. It takes, I think, 3 months to change a bad habit, like posture. So this is one thing I have them do. Another thing I have them do is cross their arms, like Barbara Eden from Dream of Jeannie, and point your elbows to the ceiling as you look up. And don't let your head go as far as your arms. Now, he's extending through his upper back and he's opening up this thoracic spine and getting extension, which is going to help his shoulder function long term and take stress off of his neck. See, there's nothing that I really have to do to him. He just needs to work on this like every couple hours at work, get rid of some of the flexion stress. And the other thing that I don't know how much I can comment on it is just regular stress and anxiety from work. Not that you don't have pain because you're overworked and stressed, but when we hold ourselves, when a boss we have to have something into our boss, when we're overloaded or things aren't running right, we tend to flex in and clench on ourselves for some reason. And what we need to do is we need to kind of chin tuck and open up and try and manage the stress the best we can by not putting ourselves in that tense posture. You know, we clench our teeth, and that all has ramifications down through the neck. So, again, Rochester General Physical Therapy, we try and concentrate. We're like CSI of the body. There's a crime scene here somewhere. There's pain. We're trying to figure out, yeah, the crime scene occurred here. The crime scene is here. This is the pain. But where is the culprit, and where can we fix it? And it's kind of a fun job because, you know, every person's a puzzle. Not every person's the same. Not every rotator cuff is the same. Not every total knee is the same. Everybody's different.
Yeah, and these exercises are easy enough because there's no equipment, right? You don't need a chair. That's what you need, a chair and your head on your shoulders. So you do these frequently throughout the day, keeping right good posture. You're going to keep better alignment. Like Jim said, you're going to decompress that area and help also with these outer symptoms you may have in the shoulder, maybe coming from stiffness or tightness you may have or inappropriate alignment in that neck and upper thoracic region.
I just had a quote, there was just a quote I came across, something about exercise takes the place of many medicines, but there's no medicine or pill that can take the place of exercise. We're movement scientists, we're made to move.
Yeah.
If you're going someplace and somebody's applying a passive modality on you and not getting you to move or improve your movement or your quality of movement, then you got to question them and find out why you aren't exercising and moving more. We're just trying to help you move better. We can't fix you. You got to be a part of our team and help us fix you.
Well, thanks for your time. Again, we're Rochester Regional Physical Therapy at Midtown Athletic Club.